Welcome to the botiss podcast. I am Jacek from botiss, and today I have a very special guest from Austria. His name is Dr. Frank Kloss. He lives in the beautiful city of Linz in Austria. He is a maxillofacial surgeon, so he is working in his private practice in Austria. And he's also an international speaker, so he has been lecturing at different events and congresses in France, in Denmark, in the United Kingdom on the topic of bone regeneration. So we are very happy today to have Dr. Frank Kloss here. Dr. Frank Kloss will be interviewed by my colleague Lisa. Lisa has been working at botiss for many years, and she is an expert for allografts, in particular for the maxgraft bone blocks. So I am now handing over the words to my colleague Lisa.
Thank you, Jacek, for your kind introduction. And hello, welcome, Frank. Nice to have you here today, that you found the time. And maybe you can introduce yourself to our listeners. Who is Frank Kloss?
Well, Lisa and Jacek, thank you for the invitation. Who is Frank Kloss? Well, I'm a small oromaxillofacial surgeon working really at the countryside in Austria. And when I started in Erlangen in Germany at Professor Neukamp's department, and this is where I got into contact with implantology. And then for almost 10 years I have been working at the University of Innsbruck as an oromaxillofacial surgeon, and now for almost 8 years I'm working in Linz, which is located in the southern part of Austria. And of course, now in my private practice, it's much more the daily life of oral surgeons or oromaxillofacial surgeons, and with one specialty, which is the augmentation and the reconstruction of all alveolar ridges. And this is why I'm here today, to share my experience with the maxgraft allogenic bone blocks in the reconstruction of alveolar ridges. So I'm really happy to have you at my side, botiss, because you helped me to overcome all these cases.
Yeah, thank you, Frank. So also for our listeners, so what are your daily routines in the practice? Which procedures do you perform often? And you mentioned you have a long years experience with botiss, and I would like to know what was maybe the first experience and which product of botiss you used first.
Well, I got introduced to the maxgraft product, well, it's more than 7.5 years ago. And it was a Bonebuilder because it was offered to me as a perfect solution for especially difficult cases. And it was actually a case where one tooth was missing with a huge defect in the vertical dimension. And I thought, well, it is pretty difficult, so this might be the best option to do, a Bonebuilder in this case.
Yeah, maybe for our listeners, the maxgraft Bonebuilder, what is it exactly? It's a customized bone block made from cancellous bone, and it is a 3D designed and then milled bone block.
Yes. So I became the chance to use this individualized bone block in this patient, and well, as I just mentioned, everything went wrong because I had no experience with that product, so I did everything wrong which can go wrong. So, but this was a good school for me, because this case I learned very, very much, and well, we can talk about that in a minute. But this was my very first case, and I didn't feel disappointed because after looking at the x-rays, I immediately knew that it was my fault and not the fault of the product. So that was the start of my learning curve with those allogenic bone blocks. And yes, you were right. You were right. It was a cancellous bone block, and it was adapted to the patient's needs. Yes.
Yeah, and that's also what I liked when I met you the first time. You are also doing courses and giving lectures, and that you also show other clinicians what is the learning curve, and maybe from your first cases what can be done better, or also to avoid problems which you had or experiences, then also for the other clinicians. That's really nice to learn.
Well, I think especially in courses, this is the most important thing, to show the colleagues things that will end up in a mess, because you always learn from the faults of the others, and only to show what works will not help anyone, especially when he wants to learn things. So that's why I try to show also, especially my cases where things went wrong or almost went wrong. So I think this is important. And so to go more into detail, I think when I started with those bone blocks, allogenic bone blocks, I was used to work with the iliac crest bone, where we know that there is actually resorption over the time during the healing period. And that is why you feel you have to overcorrect situations, because then you might end up in a perfect situation. And this is what I did with those allogenic bone blocks. But maxgraft doesn't need it in that extension. And this is what I had to learn in my very first cases, that there is no need to massively overcorrect a situation. And but this is something you have to learn, and I think it is important to show in courses what happens when you try to overcorrect situations.
And do you personally also use genogenic bone substitute as a kind of resorption protection, or what is your experience about this?
Well, yes. So during the last 7 years, of course, I tried several things. But, I finally ended up using Genogenic bone graft, cerabone, as a thin layer on top of this adapted bone block and cover it by a chasen membrane. I started with that regime, but then I left it sometimes and just used allogenic bone particles, maxgraft bone particles, but then came back because I think for a long-term stability it might be perfect to have a thin layer of xenogenic bone graft which might not resorb in the end.
Yeah, and on your website, one can see you have also a very long list of publications. So you have been working before your private practice, also at university clinics, and doing also maxillofacial oral surgery. And you also published a paper about bone blocks in a 12 months retrospective analysis. Maybe we can talk a little bit about the results of this. What's your experience after 1 year, or also in a longer time period?
Yeah, so the idea for this publication was my observation of those cases I did with the maxgraft bone blocks, because in former times I used to work with autogenous bone, especially from the ramus for smaller defects. And of course this cortical bone didn't show a lot of resorption at the re-entry and even after a longer time period. But working with the maxgraft bone blocks, I observed that I do not have a lot of resorption as well. So I thought it might be interesting to really investigate the behavior of those maxgraft bone blocks with respect to resorption characteristics. And this is why we measured CBCT scans. And we measured them before augmentation, right after augmentation, and followed it up to 1 year. And that was really impressive to show it in these data that they behaved pretty much the same. So the maxgraft allogenic cancellous bone blocks behaved the same way as the cortical bone that we gained from the ramus. And I think this is a really nice result. And now we are planning to do a follow-up study after 3 years, which we started doing those x-rays in those patients, and it is promising. So because it behaves pretty much the same.
Yeah, we're really looking forward to see long-term follow-up. And now also speaking about publications, so this study with 1 year results was about the maxgraft bone blocks. And you also published a short time ago another case report from a maxgraft Bonebuilder with a 5 years follow-up, which was also really interesting to see what happens after 5 years.
Yeah, so we had the chance in one patient to come back to the situs where we did the augmentation with a Bonebuilder, which is, as you said before, an individualized bone block where we did horizontal augmentation. And as we were right at the operation site, the patient agreed that we were allowed to take a biopsy, because so far in literature we did not find a real hint in a patient what happens to those bone builders after 5 years. So some of the colleagues says, these bone blocks might remain and there is no complete remodeling. But what we find histologically was that there was no sign for any remnants of these Bonebuilder material. So that no allogenic bone right there or any foreign body. It was a nice, well-vascularized laminar bone right there. So this is the first hint that the Bonebuilder or also the maxgraft cancellous bone blocks might be remodeled completely after a certain time period. I'm sure it depends on the size of the bone block, definitely. But at least after 5 years, we were able to show that there were no remnants left.
Yeah, that was really an interesting result. And speaking about the town you're living and also the patients who usually come to your practice, I often hear from clinicians that once they start with the maxgraft blocks, that big part of the patients would rather choose a maxgraft block than an autogenous bone block. If they discuss the various options with the clinicians. So what's your experience? How does your patient react if you mention that there's the possibility of an allogenic bone block?
Well, I can tell you that the situation changed a lot from the beginning when I started using those allogenic bone blocks up to now. In the beginning, I had a couple of patients choosing the allogenic bone blocks. But by learning how to handle those bone blocks and to see the positive results, of course, one can discuss with the patients the advantages and disadvantages of both techniques, autogenous bone versus allogenic bone. And meanwhile, it's about 70 to 80% of the patients choosing the allogenic bone blocks and try to avoid a second surgery means the donor side or even the donor side morbidity. And this is really a big issue for the patients, because they love to go to work after 3 days or after 2 or 3 days, or even after on the next day, which is much more likely to happen compared to autogenous bone, especially when you think about iliac bone graft harvesting. Then patients really have to be in hospital, and this is what they try to avoid. So now, as I have actually experience on that topic, I can say that, yeah, at least 80%, I guess, now choose or prefer the allogenic bone blocks compared to autogenous bone.
Yeah, that's also interesting to hear for us here. What patients prefer, one or the other technique. And you mentioned before you also use with the big block augmentations our Jason membrane, the native pericardium membrane. Maybe we can talk a little bit about that, because some clinicians prefer to not use a membrane, or what's your opinion about that?
Well, so my current treatment regime is definitely using a membrane on top of the cancellous bone blocks. Especially when it comes to augmentation procedures. Yes, I know that the periosteum is one of the best membranes you might have, but you always have to cover your defect, which means you have to incise the periosteum. And whenever I have to incise the periosteum and that way damage the periosteum, I prefer to use a membrane on top of my augmentation site. Moreover, whenever the patient is willing to do, I put on top of that membrane a PRF membrane as well, to boost the soft tissue healing as well, because I really want to avoid any complication on my augmentation site, and everything that might help to have a good and uneventful healing, I will do. And now, as I use the Jason membranes also for more than 7 years, I can say it is a perfect membrane, especially for those augmentation sites. Just by the way, I tried some different membranes, but so far I had none that is, well, really nicely adapting itself to the augmentation site, and that's why I really, really like the Jason membrane.
Yeah, good to hear. And you also mentioned complications which can happen always if it's a big surgery. And I wanted just to know what's your experience. As far as I can remember, at least in this paper with the maxgraft bone blocks, you mentioned there was in these cases, I think it was 20 patients with the maxgraft bone block and 20 patients with the autogenous bone block. You didn't experience any bigger complications so far.
Well, to be honest, I do not have many complications with this kind of augmentation. When I left the way to overcorrect my augmentation sites, when I started leaving this way, I didn't observe a lot of complications. Yes, sometimes when I have really large augmentations, means more than 3 to 4 teeth, yes, it is sometimes hard to cover it, to cover the clinical situation, and there might be a wound healing disorder, but this is also something very interesting compared to autogenous bone. In my experience, I do not lose the complete bone block when there is a small dehiscence. And you might have a little loss, but not the complete bone block. And this is a pretty much different story when it comes to autogenous bone, where you actually can remove it when there is any wound dehiscence. This is very interesting.
So you often can implant like the same way. Maybe you need to augment a little bit more afterwards.
Well, fortunately, it's not often, as I said. But when it occurs, yes, I'm actually always able to put an implant in that site. Yeah, but which is not possible with the autogenous bone, in my experience, actually. Yeah.
Yeah. And what can you give our listeners maybe as a recommendation if they start with bone blocks or would like to try it? You've already mentioned maybe to start with a not so complicated case, and also to learn from others.
So first of all, I would like to say that you should not start, as you said, with a complicated case, because of course it seems very easy to send a cone beam CT scan to the company, receive a bone block and try to put it into the patient and everything is fine. This might end up in a mess. So in my opinion, one should start with a single tooth treatment where you might have an exit strategy, and just to get a feeling for the material. So after my first horror experience, I went back and used it in a patients where I knew I have some exit strategy options, like putting a little displaced implant, or I can use a diameter reduced implant, which might be not perfect, but somehow we can overcome the situation. And with that, I learned how the material behaves and what I have to do. And then, of course, when you know how it works, then you can come back and use it in more difficult cases. I think this is very important. And as I mentioned before, another thing is that you should not overcorrect the blocks in the clinical situation, especially in vertical dimension. When you try to come up to a height which is much more over the bone to the adjacent teeth, this will not work, mainly at least. Yeah. So be really careful not to overcorrect those bone blocks. And yes, my recommendation is to put a thin layer of cerabone on top of that bone block, and at least my treatment regime is to cover it with a Jason membrane, and if you have it in your private practice, you can even top it with a PRF membrane. And I think this is a pretty safe procedure, yes.
Yeah, thank you for the detailed explanation. And so as we've heard today, you're quite busy, so you have a daily practice, you publish also case reports and studies, and you're also one of our lecturers at the Human Cadaver course in Vienna, where people, as we've said, can learn from you and also from your learning curve. So the next Human Cadaver course will be hopefully next November in a year. And you will be not only talking about the maxgraft bone blocks, but also the maxgraft Bonebuilder, the customized bone block, and also maxgraft cortico, which is our cortical plates for the shell technique. Maybe we can talk a little bit about your experience with these cortical plates.
Well, so I think it is now 3 or 4 years ago I got introduced to the cortical plates, and well, to be honest, in the beginning I was not sure if I want to have another learning curve, but I faced clinical situations where it's pretty tough to adapt a cancellous bone block. Sometimes because it is very thin situation, or a very a situation where you might have to remove bone to get a nice adaptation of the bone block. And then I started to try those cortical plates, and I thought, well, it is a very nice tool in my toolbox to especially overcome situations where the defect is not that deep, but you have to augment. So like some people might use GBR technique or something like that. But with a cortical plate, you have a really stable membrane outside or even on top of your defect. And so you can really trust in the healing of the underlying defect. And this was the starting point, using the cortical plates. And meanwhile, I'm happy to have this tool because especially in the mandible, in the posterior side, where you very often have a shape of the bone where it's pretty tough to place this cancellous bone block, especially when it comes to the vertical augmentation. Here you can really build up like a box with the cortical plates, fill it up, in my case with allogenic bone particles in combination with the cerabone bone particles, and fill it up and cover it with this stable cortical membrane. I call it a membrane. Of course, I know it's a cortical strut, but actually it's working as a membrane. Yeah. So I'm really happy to have this. And so far I had also experience with that, and I'm happy to really show the results of my treatments at the cadaver course in Vienna. So I think this is a good tool, and I'm happy that we now can show it also in the cadaver course.
Yeah, so we will also, for our listeners, we will put also all the links and more resources on the cadaver course, and also information on maxgraft on the website beneath the podcast, so where you can find then more information.
Well, that's nice. And well, it is always a nice course because it is an international course, and you can get in contact with many colleagues from all over the world, and really from South America, from Asia, from all over the world. And it is also fruitful discussion going on at the course, because every country has its own experience, and it's a very interactive course. So I just can make advertisement for the course in Vienna, and hopefully some of the listeners might join us next year.
Yeah, that would be really great. So thank you, Frank, for sharing your experience. And I hope everybody enjoyed today's podcast. And stay tuned for our next episodes.
Well, Lisa, thank you very much for inviting me to have this discussion with you. It's always a pleasure, and well, see you next time, or maybe in Vienna. Thank you very much.